All right, let's dive into a bit of a medical mystery today. We're going to be detectives on the trail of a really sneaky threat, a dangerous clog that can hide out in one of the most important supply lines to the brain, the carotid artery. So we'll follow the clues, look at the evidence, and see exactly how doctors crack the case of what's called carotid stenosis. So what's really at stake here? Well, it all comes down to this number, 10%. That's the percentage of all strokes caused by this one condition. It's a silent problem with, potentially devastating consequences, and that's exactly why catching it early is so incredibly important. So the main culprit behind this dangerous clog has a name you've probably heard, atherosclerosis. The easiest way to think about it is like rust building up inside a pipe. Over time, these fatty deposits, we call them plaque, they just build up on the artery walls. This gunk hardens, it narrows the whole passage, and that restricts blood flow, setting the stage for a stroke. So how does this whole investigation usually get started? Well, you might be surprised. It often begins not with some fancy high-tech scan, but with a simple, kind of old-school clue that a doctor can literally hear during a routine checkup. And that first clue is called a carotid bruit. See, when an artery gets all narrowed, blood can't flow smoothly anymore. It gets all turbulent, kind of like water rushing through a really tight space. And that creates this distinct whooshing sound. So for a doctor who's listening with a stethoscope, hearing that bruit is the first big tip-off that, hey, there might be a blockage in there we need to investigate. And you might be wondering, okay, but how reliable is this sound clue? Well, just take a look at this chart. If you look at the bar on the right, that's the general population. Only about 4 to 5% of people have this sound. But now, look at the bar on the left. These are patients with severe stenosis. We're talking an artery that's over 75% blocked. That number just skyrockets to a massive 70 to 89%. Wow. That's why this simple sound is such a powerful first clue. Okay, so once that first clue is found, it's time to bring in the heavy-duty investigative tools. We're about to look at the advanced imaging tech that doctors use to get a really clear picture of what's going on inside that artery and, the clinical trade-offs they have to think about. So the first tool that gets deployed is almost always ultrasonography. It just uses sound waves to create a picture of the artery. It's totally non-invasive, it's easy to use, and really it's the perfect screening test to get an initial look at the scene and see if there's really a case here to pursue. And it's an excellent tool for spotting specific things like ulcers or even bleeding inside the plaque itself. But there's a major downside. The accuracy of the results really, really depends on the skill of the person doing the scan. It's that classic trade-off, right? Accessibility versus precision. Now, for a much more detailed picture, the investigators turn to MRI and MRA. You can think of this as bringing in the forensics team. MRI gives you these amazing high-contrast images of the vessel wall and the plaque, while MRA is specialized to track the actual movement of blood. And this is where we get really deep into the evidence. MRI is just fantastic for analyzing what the plaque is actually made of. MRA technology then hones in on the blood flow by basically erasing the image of all the static tissue around it. And get this, some techniques, like time-of-flight MRA, can produce these incredible, high-quality images without needing a contrast agent injection, which is a huge plus for the patient. Sometimes, though, the most critical factor isn't just detail, it's speed. And for that, there's computed tomography angiography, or CTA. This tool is all about one thing: getting detailed images and getting them fast. The biggest advantage of CTA is its incredibly short image acquisition time. I mean, it's fast. It creates these detailed reconstructions from multiple angles, meaning doctors can see the artery from any which way, almost like a 3D model. And that is crucial for finding blockages in arteries that are really curved or twisted. But the trade-offs are pretty significant. It requires a contrast agent, and it does expose the patient to radiation. And finally, we get to the test that provides the definitive slam-dunk evidence, digital subtraction angiography, or DSA. This one is considered the ultimate authority in this investigation, and well, the clarity of this image kind of shows you why. I mean, don't just take my word for it. The source material calls it, and I'm quoting here, the gold standard test with the highest accuracy for determining the degree of carotid stenosis. When you need the most precise measurement you can possibly get, this is the test you turn to. So why is it the gold standard? Well, for one, it's got the highest accuracy. It can clearly tell the difference between a vessel that's 100% blocked and one that's almost blocked, and that's a huge distinction for treatment. It's also the best tool out there for finding what are called tandem lesions, which is where there's a blockage in the neck and another one up inside the skull. That's a complication other scans might totally miss. Okay, so with all this amazing evidence gathered from our toolkit, the final phase of the investigation can begin, analyzing all that data to officially classify just how severe this threat really is. The classification system is actually pretty straightforward. It's broken down into 3 clear degrees. Mild stenosis is when the artery is less than 50% blocked. Moderate is a blockage somewhere between 51 and 69%, and severe stenosis is anything from 70% all the way up to 99% blocked. And this final classification is absolutely key for deciding what to do next. And to make sure that every doctor is measuring the exact same way, they use a standardized formula. Now, there are a few methods out there, but the most common one used today is called the NOSCET method. It just provides a consistent, reliable way to calculate that final critical percentage. So the investigation is complete. The evidence has been analyzed, the threat is quantified. Now comes the verdict, the decision that is going to determine the patient's entire course of treatment. And that verdict usually leads down one of 2 paths. For the less severe cases, the choice is typically medical management, so using medications like antiplatelets and statins, combined with lifestyle changes. For more severe stenosis, the evidence often points towards surgical interventions, like literally cleaning out the artery or placing a stent to hold it open. And this brings us to a final and really fascinating question. We know that our modern medical treatments are getting incredibly good at preventing strokes. I mean, some studies show the annual stroke risk can be less than 1% with the right meds. So, as our medicines get better and better, the central challenge becomes, how do we figure out who that small group of patients is that still genuinely needs a high-risk invasive procedure? That is the next medical mystery we all have to solve.